Good morning, everyone. My name is David CRAWFORD. I'm a professor of urology at the University of California in San Diego. I want to thank the organizers and all of you for the opportunity to do this presentation this morning. Being in Hong Kong is one of my favorite places to be. My wife and I have been there many times, and sorry we can't be there live today. So my talk is focusing on ADT. I've spent a lot of my career in the area of androgen deprivation therapy and seen a lot of progress over the past several decades. So the outline, the goal is of ADT. We're going to talk about that, methods of ADT, side effects of ADT, delivery on time of ADT. Talk a little bit about all the excitement with metastatic hormone-sensitive prostate cancer right now and a pathway forward. We know there's a strong history in androgen deprivation therapy. You can actually stretch it back to the 1700s when Hunter castrated animals. And then we know that there's 2 Nobel Prizes for ADT, Huggins and Hodges, Huggins here, and also my good friend Andrew Shalley. We've seen a lot of variation in ADT over the years, and also the first tumor marker in oncology was acid phosphatase, and PSA is also an important thing and part of ADT. We know that the control of the androgens is predicated on the path of an intact hypothalamic pituitary testicular axis, and testosterone is developed. We know that some testosterone comes from the adrenal glands. This gives us many opportunities to interfere with the production or binding of testosterone to the receptors that we can integrate in the management of prostate cancer, because we know that prostate cancer is an androgen-dependent cancer. Testosterone's the king here, and testosterone is chaperoned to the extracellular space by sex hormone binding globulin, is released. It is picked up by the androgen receptor as seen here and translocates into nucleus where growth occurs. ADT is the foundation of care, and as we can see here, we want it as low as possible. Prostate cancer is androgen dependent. The primary ligand is testosterone, and our goal is to maintain and keep testosterone as low as possible. We want to maximally deprive the tumor environment, and there's multiple ways we can do this, and we're going to talk about that in the next few minutes. Well, what is the castrate level of testosterone? If you look at our FDA in the US, it says less than 50, but that was because when a lot of the studies were done, they were done in an era where we couldn't measure testosterone by mass spec down to 0. Now we know with bilateral orchiectomy and other ways that you get your testosterone down less than 20, and that's the goal, and to keep it there. So why do we still use these older technologies? I don't know. But let's look at the future. We want to keep it low. Why? I could spend 15 minutes talking about all these different studies, Marodi, Pericano, Lori Kloss, but they're all a number of studies that show that there is a clinical benefit, a survival benefit, as seen right here with these check marks, when you keep testosterone levels less than 20. The guideline targets, what do organizations say? We got together in Bethesda in 2012 and said, hey, 20. The EAU was an early adopter, less than 20. Canadian Urological, NCCN was less than 50. Recently, they and the AUA have updated this. So initiation of ADT, where do we use it? We use it for high-risk localized disease, biochemical failure, newly and diagnosed metastatic disease, and also continuing ADT as a foundation during castrate-resistant states. So what I'm saying here is that ADT is the foundation. How do we do it? We'll go through some of these things: bilateral orchiectomy, agonist, antagonist, and anti-androgen. But again, this is an important statement. And all these stages of prostate cancer, local, biochemical failure, advanced, where we use ADT, what we want to do is get the T less than 20 and to keep it there. All right, bilateral orchiectomy, been around for a long time. It's the gold standard. And there are some advantages and there's disadvantages, and we know what most of those are. But if you look at one of the things that with bilateral orchiectomy is an elevated FSH, which may be responsible for some of the side effects that you see more with bilateral orchiectomy than you do with LHRH agonists and antagonists. Then we have the third generation anti-androgens. What they do is bind to the receptor. If we had a treatment option that would really work with an anti-androgen, it would be the best treatment for advanced prostate cancer. But anti-androgens, first, second, and third generation, have variability in binding to the receptor, so they need a little help by lowering testosterone. We'll get to those in a minute. So LHRH and agonist and antagonist. This was really the breakthrough when the 1 month EPO came along. Now we got 3 month, 4 months, 6 month, 12 months. And we got many different formulations of IM, sub-Q, and we've had implants that we've used with LHRH agonist. One of the first studies that came out with LHRH agonist was our study in 1989, where we combined it with an anti-androgen, published it in New England Journal of Medicine, and extended survival rate by lowering testosterone even more with blocking the receptor with an anti-androgen. At that time, it was called flutamide. We've come a long way. We know there's a difference between agonist and antagonist. And then agonist, what it does is basically deplete the hypothalamic pituitary area, the pituitary. And right when you first give it, you get a flare. With an antagonist, you don't see that. So what happens is it takes a while, several days, for the FSH and LH to cut down. So testosterone cuts down with an agonist, as you well know. With an antagonist, it's more immediate gratification of lowering testosterone. This is a summary of what's out there, at least in the U.S. We have sub-Q. This would be a drug like Eligard. IM, this would be Lupron, and triptorelin is Trelstar. Glycerin is Zoladex, and then we have Degarelix and Relagolix, which are Firmagon, and we have the oral Relagolix. Well, let's look at suppression with Relagolix. This is Neil Shore's study in the England Journal of Medicine almost 2 years ago now with Relagolix. And what we see here is that there's a more immediate drop in testosterone with the antagonist and the agonist, but then it catches up after week 3 and maintains castrate levels very nicely. Both of them do. And then when you stop at least the oral drug, Relagolix, in this study, there was more of a bounce in testosterone. What are some of the issues with LHRH agonist and to some degree antagonist? But this is more agonist. Flare is one issue that's detrimental. Onset, how quickly you can lower T, can be detrimental, particularly if it takes a while and you've got some precarious spinal cord metastases or urinary retention. You want to keep the T less than 50, less than 20, I think. And we know that there are escapes that occur when you use these drugs. Also, the nadir testosterone level is important, and we want to keep it as low as possible. We know that, and I'll show you this in a minute, when you deliver these drugs late or and mostly the agonist, what you see is an acute on chronic or microsurges. We have shown, and others have shown, that this blurps in the testosterone that occur with depot injections is associated with the rise of a PSA and some other detrimental side effects. And we know that not everyone responds to LHRH agonists, no matter what drug it is. There's always some escapes, and there's many reasons for that. If you think about it, we give the same dose to a person who is 300 pounds or many kilograms versus some person that weighs less. Well, there are some quality of life issues and medical issues associated with ADT. The quality of life things are hot flashes, loss of libido, erectile dysfunction, fatigue. The medical issues are osteoporosis, diabetes, neurocognitive, and it goes on and on and on. And the one on sort of the front stage right now is cardiovascular issues with LHRH agonists and antagonists. This is just a paper we presented at the European Association of Urology meeting just recently, and also in July, and also at the AUA about major cardiovascular events. And we've got a number of studies we're doing like that right now. This one basically shows that what's one of the major risk factors for MACE, major adverse cardiovascular events. It's a history of them. And if you didn't have one, it's not so high. So this is over a 4-year period with some 43,000 patients injections of an LHRH agonist and various LHRH agonists. We have some other papers right now we've submitted on differences between antagonist and agonist and some of the different depots. So does dosing interval, late administration affect outcome? And the answer is yes. This is an article we published 2 years ago in the Journal of Urology, looking at several thousand PSR injections, and the approval for these injections is based on a 28-day month, not a 31-day month, not an extended month. But look at this: 84% of the injections were not given according to what the studies that were done were structured as. And you can see here what that is across all of the depots here, the 1, 3, 4, and 6 month depot. And very few percent were were given on time. All right, what does it mean? If you look at T greater than 50, and we know that's associated with some bad outcomes. If you gave it early on time, it wasn't bad. It's 4 to 5%. That's what you sort of want. But if you were late, beyond, let's give you a few days, like 32 days, 30 days, what you see here is there is a significant increase in T's greater than 50, and also even more T's greater than 20. And as I said, we want to kind of keep it down in that range of 20. All right, this is another article that we have out on the differences between the formulations of the gel and also of the IM formulation. So the gel versus the microsphere. When we look at proportion of people that failed, a little bit higher with the microsphere than with the subcutaneous gel, which in most of these studies is Eligard, using something called Atrogel that's been around, a variation of that over the years. 28-day, if we look at that again, test, we see that the sub-Q outperforms the microspheres. And again, when you look at late dosing, what you see is that the gel had lower testosterones compared to the microspheres. And this was in our paper in the Journal of Urology this last year on this. I want to move into something else that I think that's hot topic right now as I finish up here, and that is monotherapy versus doublets or triplets in the management of newly diagnosed or people that metastatic disease, whether they are de novo or have evolved after failing the local therapy. What we see here is androgen deprivation monotherapy has been foundational, yet limited poor clinical outcomes. The tumor burden, things like that. I'm going to show you some things, a couple of studies in a minute here. New standard of care is not monotherapy, but it's doublets and now even triplets. And these are in the new AUA and NCCN guidelines. I showed you our study with a first-generation anti-androgen had a 26% improvement in survival rate. And that translates into about 6 months. That's a lot when you look at what we're getting right now. And a lot of the studies, and this is a weakness in many of these studies that I might show you, as the control was not a first-generation anti-androgen, but a placebo. Look at the impact. This was a study done on 1,500 patients and what physicians did. Look at this. Only 24% of these physicians, urologists, used a doublet. So what they did is monotherapy, and they might have used an anti-androgen for a short period of time. Metastatic castrate-resistant prostate, castrate-sensitive prostate cancer patients can present de novo, newly diagnosed, or recurrent after failing radiation, surgery, things like that. There are different performance statuses, different tumor burdens, and varying use of adjuvant therapy. These are all things that you need to put in and think about when we're talking about precision medicine and tailoring therapy. What do we have out there for newly diagnosed metastatic castrate-sensitive prostate cancer? We've got a whole laundry list, and every one of these studies shows a benefit. Going back to Chris Sweeney's study with a 17-month benefit when you use docetaxel, then playing around with other things, androgen biosynthesis inhibitors, abiraterone, apalutamide, enzalutamide, all these things out there we have data on, and I'll show you that in a minute. These are all the studies. I'm not going to go through them all, chart it. I just mentioned that. And if you look at the benefit, significant hazard ratios all the way down for all of these, Stampede, Latitude, Enzymit with enzalutamide, Arches, Titan, and now we have a new one with a triplet called Aerosense that uses the combination of ADT, docetaxel, and darolutamide in patients with newly diagnosed metastatic disease with a significant survival benefit. Is monotherapy appropriate for metastatic hormone-sensitive prostate cancer? I don't think so. We have data going back to 1989 where we showed 6 months. Charted showed a benefit, 13 months or more. Stampede, Latitude, and it goes on and on and on. So I don't think it's acceptable to do that anymore. Conclusions: treatment of metastatic hormone-sensitive prostate cancer has undergone significant changes in the last several decades. We have new drugs, chemotherapy, apalutamide, enzalutamide, now darolutamide. Significant improvement in survival has occurred, and there wasn't any huge increase in side effects. Direct and potent drugs like these, apalutamide, enzalutamide, now darolutamide, might be a better choice over docetaxel, but now we have data that brings docetaxel back into the picture. Monotherapy is no longer acceptable, and I find it deplorable that less than 30% of people are offered monotherapy. The last thing I want to talk about is the primary and should the prostate be treated? There's a lot of discussion about this oligometastatic disease, treating the primary and things like that. I think, and we've been doing this for almost 2 decades now, is treating the primary in patients with metastatic disease with things like cryotherapy. There's some studies with radiation I'll show you. I think it's important that this is part of the discussion. What's the biological reason? The primary tumor in prostate secretes oncosomes and other growth factors that prepare the metastatic niche for implant and growth. And we also know that, so you're eliminating that. Destruction of cells in the prostate prime T cells and may have some effect on micrometastatic disease. That's called the abscopal effect. People toss that around a lot. And I've seen it in patients we've done partial cryotherapy, targeted therapy, focal therapy on, where their whole prostate involutes. Their PSA goes way down beyond what we treated. So there is a biological mechanism that, and we know that tumor interchange between the primary and the metastases do occur. What articles are out there? Well, I don't have a lot to show you. We do have some retrospective and studies that were done. 2-year survival of radical prostatectomy versus IMRT was better in patients who had no local therapy. lower tumor burden was important. So again, there was an appearance of a difference, but again, the study was small and that was not overly statistically significant. Ken Pienta, others have looked at the emerging role of local therapy. There's the Stampede, the HORAD study, and other ones that would suggest a value to treating the primary there. Look at this. This is something we published from our SWOG data in 2002 and talked about the impact of local therapy on subsequent metastatic disease. And we showed that people that had a prior local therapy actually did better with metastatic prostate cancer than people that didn't. That's another way to look at it. So to treat the primary, I think that we have some pretty good data to do it. Thank you so much for your time. I enjoyed doing this presentation. I hope you did too, and glad to discuss things. Thank you.